Acynotic congenital heart diseases. Classification. Acynotic congenital heart defects. Left to right shunts and obstructive lesions. Left to right shunts. What does that mean? Oxygenated blood is getting mixed with deoxygenated blood, and hence there is no cyanosis. Atrial septal defect, 5 to 10% cases. Ventricular septal defect, which is most common, seen in 25% cases. Patent ductus arteriosus. Obstructive lesion is coarctation of aorta. So acynotic heart diseases is again divided into left to right shunts and also obstructive lesions. Obstructive lesions is coarctation of aorta. Left to right shunts means oxygenated blood is getting mixed with deoxygenated blood, and hence there is no cyanosis. Most common, seen in 25%, is ventricular septal defect. Seen in 10% is atrial septal defect and patent ductus arteriosus. Ventricular septal defects types. Outlet subarterial VSD, also known as doubly commuted VSD. Defect in area, defecting surrounding structures like aorta, pulmonary arteries. Increased risk of aortic defect, most common is aortic regurgitation. Defect in area, defect in surrounding structures, aorta, pulmonary arteries. Increased risk of aortic defect, most common is aortic regurgitation. That is known as outlet or subarterial VSD, also known as doubly comminuted VSD. Perimembranous VSD, most common. A defect in the upper membranous part of interventricular septum. Defect in the upper membranous part of interventricular septum is called perimembranous VSD. Muscular VSD, defect in lower muscular part of interventricular septum. Increased rate of spontaneous closure, Swiss cheese pattern, variant with multiple defects. Variant with multiple defects is Swiss cheese pattern. Muscular defect, defect in lower muscular part of IVS. Inlet VSD, never closes spontaneously. Increased risk of wall defects, most common is mitral wall. Inlet VSD, never closes spontaneously. Increased risk of wall defects, most common is mitral wall. Pathophysiology. What's happening here is from left atrium, oxygenated blood is going to left ventricular through the mitral wall. Here there is increased blood flow and there is delayed diastolic murmur at mitral area due to increased flow murmur. And then the blood is existing in aorta. Systemic circulation. Deoxygenated blood is entering in right atrium and then right ventricle, but because of the defect in the ventricle septum VSD, oxygenated blood is also coming to the right ventricle. This is a turbulent flow and you will see a pansystolic murmur, shunt murmur at left parasternal area of fourth intercostal space. Increase, and then the mixed blood is going into left atrium, where due to increased blood flow at mitral wall you will see delayed diastolic murmurs. Increased blood flow at pulmonary arteries, you see ejection systolic murmur, flow murmur. Note, shunt murmurs are diagnostic, flow murmurs are not diagnostic. X-ray, cardiothoracic ratio. CT ratio equals to A plus B divided by C, where A plus B is the widest length on each side. C is the length of the thorax. So A plus B divided by C is your CT ratio. Normal value in children is less than 0.55. Infant is less than 0.6. Increase amount of blood to left ventricular, enlargement of left ventricular, cardiac outline is increased, apex is pushed forward. Higher value in cardiomegaly, increased CT ratio seen in VSD. Complication, early complication, increased blood congestive cardiac failure, systemic circulation, blood is coming into right atrium, then going into right ventricle, mixed blood is coming from left ventricle to right ventricle through VSD. This is causing forceful flows, right wall injury, increased risk of infective endocarditis. Most common is Streptococcus viridans. And then it's going to lungs, blood flow, congestion, recurrent pneumonia. Then it's going to pulmonary veins and left atrium, and then left ventricle, and then aorta. Late complication is Eisenmenger syndrome. Increased blood flow to right ventricle. Increase pulmonary artery blood. That is increased blood pressure in pulmonary artery. That will cause increased right ventricular pressure increased. Chronic will cause right ventricular hypertrophy because of progressively increasing blood pressure. Pressure of right ventricle will be more than left ventricle eventually. Reversal of right to left of shunt. Deoxygenated blood is mixing with oxygenated, and then it will occur in cyanosis. Treatment, medical management is not curative. For congestive cardiac failure, you can give digoxin and furosemide, and supportive, for example, antibiotics. Treatment, medical management is not curative. For congestive cardiac failure, you can give digoxin and furosemide, and for supportive, you can give antibiotics. Surgical management is definitive. Indication, surgical management is congestive cardiac failure even after supportive treatment. QPQS, pulmonary BF and ratio with systemic blood flow. So pulmonary blood flow is to systemic blood flow. QPQS should be more than 2:1. Associated wall defect, especially aortic regurgitation. Surgical options, closure with Dacron patch closure, percutaneous device closure. Surgical management of VSD. Indication, if congestive cardiac failure is present even after supportive treatment. QPQS is more than 2:1. That is blood flow pulmonary artery, blood flow systemic ratio is more than 2:1. Then associated wall defects, if there are associated wall defects like aortic regurgitation. Surgical options, closure with Dacron patch and percutaneous device closure. So you can do closure with Dacron patch or percutaneous device closure. Atrial septal defects types. So this is your atrial septum. Superior vena cava, inferior vena cava, and this is sinus, foramen ovale, the dotted line. So what are the types of atrial septal defect? First, sinus venosus, ASD, SVC type, which is rare, at superior vena cava opening. Sinus venosus, IVC type, rare, at inferior vena cava opening. Coronary sinus, ASD, rare, between atrium and coronary sinus. Ostium secundum, ASD, defect in upper part of septum, most common. And this is the second most common, ostium secundum. Ostium primum, ASD, defect in lower part of septum associated with wall defects, especially mitral insufficiency, conduction defects due to location. So here you have a diagram. Blood is coming to right atrium. Also oxygenated blood is coming from left atrium through the atrial septal defect. This is a minimal pressure difference between right atrium and left atrium. So this is a smooth flow. There are no shunt murmurs. Shunt murmurs are diagnostics, if you remember. Then there is an increased blood flow to right ventricular. This will call delayed diastolic murmurs, but a flow murmur. Then increased blood flow is going to cause ejection systolic murmurs, flow murmurs, and delayed closure of pulmonary valves. So delayed P2, wide fixed splitting of S2 diagnostic. What is the diagnostic of ASD? Wide fixed splitting of S2, because pulmonary valves are closing late. Then through pulmonary artery it's going to lungs, and then to pulmonary veins, left atrium, and then left ventricle, and then aorta. ECG findings. ECG done to determine location of ASD. Ostium secundum ASD. Ostium primum is ASD. Ostium secundum ASD, right axis deviation. ECG is done to determine location of ASD. Ostium second ASD will have right axis deviation. Your ostium secundum is here. Ostium primum is next to it. Ostium primum will have left axis deviation. Left axis deviation is due to left fascicular block and mitral wall insufficiency, left chamber overload. Treatment: elective surgical closure. Indication: ASD is in more than 3 to 5-year-old up to school going age. No spontaneous closure, and size is more than 8 mm. Early surgical closure indication: uncontrolled congestive cardiac failure, and QPQS ratio is more than 2:1. Patent ductus arteriosus. Incidence preterm. Kept patent by prostaglandin, and it is more common in preterm compared to term babies. Association of patent ductus arteriosus is congenital rubella. Pathophysiology: aorta via patent ductus arteriosus, pulmonary artery goes to pulmonary artery. Turbulent flow due to large pressure difference causes shunt murmurs. Site: peristernal area of second and left intercostal space. Nature: loud continuous machinery murmur. Complication: congestion due to increased blood flow. In lungs, first recurrent pneumonia. In heart, congestive cardiac failure. Second, Eisenmenger syndrome, reversal of shunt, late complication. Here is a diagram of Eisenmengerism. So aorta, and then only lower limbs cyanosis. You have your aorta, upper limbs, and then descending aorta, and then the patent ductus arteriosus is opening after upper limbs openings. So PDA with reversal of shunt, descending aorta. Only lower limb cyanosis is a differential diagnosis of Eisenmengerism. Management: medical, supportive. Is calcium channel blockers like digoxin and furosemide, Pneumonia, you give antibiotics. Curative only in preterm babies, NSAIDs. It decreases prostaglandin production and it causes closure of PDA. Ibuprofen is preferred more than indomethacin due to decreased risk of nephrotoxicity and necrotizing enterocolitis. Surgical indications, preterm baby not responding to medical management or contraindicated to medical management. So what are the indications in preterm baby? If they are not responding to medical management or there is a contraindication to medical management, then you go for surgery. What is contraindication to medical management? Platelet count less than 80, serum creatinine more than 1.8, any active bleeding. All term babies you can go for surgery. Technique used is ligation and percutaneous catheterization using occluders or coils. Coarctation of aorta. Most common location is juxtaductal, near ductus arteriosus. Coarctation of aorta, indentation, coarctation of aorta. So most common location is juxtaductal, near ductus arteriosus. Here is the image. Near ductus arteriosus, you see your coarctation of aorta. Features based on severity of narrowing. There is near complete closure, which is uncommon, and partial narrowing, which is more common. Near complete closure uncommon type is severely restricted blood flow and it causes a shock in neonates. There is a severely restricted blood flow and shock in neonates. Partial narrowing is most common. Decreased blood flow to descending aorta. Decreased blood flow to lower limbs, claudications, pain, feeble femoral pulses, radiofemoral delay, decreased blood flow to kidneys, ischemia, it will cause renin release, activation of RAS, increase aldosterone, renin, angiotensin, aldosterone system, and there will be hypertension present. Systemic hypertension due to increased resistance. There is a systemic hypertension due to increased resistance. Note, hypertension causes hypertensive encephalopathy, presents with seizures. Due to hypertension, there could be hypertensive encephalopathy and it can present it with seizures. Compensatory changes noted in older children, more than 10-year-olds. Formation of collaterals, blood diverted to intercostal arteries. Blood is diverted to intercostal arteries. Increased size of intercostal artery, dilated and tortuous. Pressure on lower border of the rib, inferior rib notching. So here you can see dilatation and stenosis, post-stenotic and pre-stenotic. Those are appreciated in the X-ray, chest X-ray. It's called 3 sign. Treatment: balloon dilatation of coarctation plus minus stenting. Balloon dilatation of coarctation plus minus stenting. In the next video, we'll see cyanotic congenital heart